And I would like to talk about cytogenetics. I will talk about cytogenetics point of view in our experience in Brazil, if the doctors are ordering the right tests for this kind of malignancies. So in other words, this cytogenetic is still important in B-cell malignant disease. I am responsible for a private lab, and this lab supports many hospitals and other labs. So we perform cytogenetics. We are very specific, and we support other hospitals, public and private hospitals that they don't perform cytogenetics, so they send to us, and other labs as well. So we receive samples from all over the country. So just to have an idea as a primary data, we look for 3,000 samples that we received last year. It was hematologic samples for cytogenetic analysis. And we look to see how many mature B-cell malignancies they sent to us. So it was about 111, 75 were CLL, and 36 were non-Hodgkin lymphoma, and 4 samples were for fish, were CLL and for fish. So from this hematology disease, most of them were acute leukemia, myelodysplasia, but only 4% were CLL if you consider fish. So from all the samples that we've got, only 4% were CLL. What we look when you look for the karyotypes, when we were talking about CLL now, 30% of the samples presented any clonal abnormality. Most of them present complex karyotypes that is defined as more than 3 abnormalities. But we found trisomy 12, deletion of 11q, 6q, 13q, and 14q. Of course, we can't see deletion of 7q minus. Everybody knows that it's very hard or impossible to see using conventional cytogenetics. So when we saw fish, we analyzed 40 bone marrow all peripheral blood, 23 samples. They asked for CLL panel, and half of them were for P53 or 70P minus. And 65% of these cases presented an abnormality. So when we look for conventional cytogenetics in CLL, it's a very tough work because the cells are very difficult to get, for us to get metaphases. So we have to stimulate it. I use TPA for many years. We have to leave the cells in long cultures. Usually I leave in 3 days and 5 days. The literature shows that around 30% of the cases presented any abnormality, chromosome abnormality, and complex karyotype shows to confer a poor prognosis. When you use fish, this is a gold standard to us nowadays because it's quicker. It's easier. We can scan 100. Usually we scan 200 nucleus or cells, but it's very expensive. Not very expensive, but it's more expensive than karyotype. So the panel, CLL panel, comprises P53 or 70P minus, 11q22, trisomy 12, and deletion of 30q. We use as well a probe that for heavy chain gene and a probe for MIB gene. And 8%, of course, is much more sensitive fish when you compare with karyotype. So 8% of the cases presented any abnormality. Of course, they are selected. You look what you have the abnormality, what you are looking for, of course. So this is Dr. Gia showed yesterday. Is a very classic work. It was done for the German group. So there is a very clear relationship between alterations, abnormalities, and survival. So as we can see, the group with 30q deletion have the best survival when you compare, for instance, with 7p, the group with 7p minus. 15 years later, the group of Mayo Clinic studied more than 1,500 patients, and they obtained the same results. But it's interesting because, of course, the survival scores are better when you compare 15 years ago because the treatment are getting better. But they've got the same results. This is the group with 13q deletion, and this is the group with 7q deletion, and 11q deletion was very bad as well, compared with the other curves when we compare 15 years ago. And it's interesting as well because in this work, the percentage of 70p minus that were presented was related to poor prognosis. So more than 20% of the cells with this kind of deletion has a worse survival. When we look for non-Hodgkin lymphomas in our series, we've got 36 bone marrow for karyotype, and we detect only 3 cases with abnormalities. So all these cases that had these 3 cases were mantle cell lymphoma. So everybody's familiar with the translocation, what they are, and this association with lymphoma. So Burkitt lymphoma, 100%, everybody knows that 8q or CMYC is involved with other chromosomes with 2 and 22 and 14, of course. Follicular lymphoma has the 14-18 and mantle cell lymphoma 11-14. Mouth lymphoma is interesting because depend of the involvement, the anatomic site that is involved. For instance, ocular involvement has the 3-14. But what they share in common, it's very difficult. We don't get these abnormalities by conventional cytogenetics. We have to use FISH or PCR. This is an interesting paper or work, and they look for 80 patients with mantle cell lymphoma, and 40% had complex karyotype that was associated with high risk, but almost all the patients had a disease, a spread disease, and almost all the bone marrow were involved. In this other work with extramedullary lymphoma, so the bone marrow were not involved, and they analyzed, they performed cytogenetic analysis, and only 8 cases present abnormal karyotype. So the bone marrow has to be involved to be analyzed or to get, of course, cytogenetics result. So it's interesting because every time that I receive non-Hodgkin lymphoma in our lab, I say, but why? Why they are sending us this? What they want? Because most of them don't get any result. So the preferred tissue is the lymph node that is involved. It's fresh lymph node. Bone marrow, usually we don't have any information or good information. Cytogenetics or FISH analysis should not routinely carried on bone marrow aspirate, only in Burkitt. So the conclusions are that in non-Hodgkin lymphoma there is no reason to perform cytogenetic or FISH routinely. of if it is relevant, if the doctor wants the cytogenetic, it must be done in fresh lymph nodes or in the spleen or wherever the tissue that is involved. This is important, obviously, but it's not, because we receive, as I say, many samples from bone marrow. So in bone marrow, it's useless. In CLL, fish with deletion of 7p minus before treatment is very important. We're looking for this now the percentage of deletion. I think it's it's being associated with worse outcome. We think that maybe at least the series is not a statistic, as Dr. Chiatoni said yesterday, is only a series, but maybe they are not being classified properly because we don't have many cases of CLL. And I think complex associated with increased risk of transformation. So every time that we are looking for fish, I think it's important to perform cytogenetics as well. It's the same sample, it's the same laboratory that we will analyze, although I think it's still important to perform cytogenetics. It's the only way to get any other abnormalities is performing conventional cytogenetics. So thank you for your attention.
Thank you also for keeping the time. So any question? Robin.
Yeah, thank you very much. I would start from some of the points that you correctly stated at the end. I mean, just to be very open, I mean, one of the problems, obviously, I think the interaction between the hematologist and the laboratory. I mean, you're a private laboratory, you receive samples from different centers. So I don't know how to say it, you do what they ask you to do, really. You don't discuss with, I imagine, I don't know, but I imagine what happens, knowing a bit the reality, that you don't really discuss the individual case with the hematologist. You receive the sample and they ask you to do cytogenetics or fish. Is that correct?
Yes, the problem is we are trying to talk with every doctor, because I am hematologist, I am clinician as well. So for me, it's easy to do that. When I know the doctor, I mean, when the doctor sends and I have his information, I call him and say, look, we don't have to do this kind of cytogenetics in your patient. But sometimes we receive from another lab because we support other labs. So it's difficult.
It's difficult. No,
Yes.
I understand. Because this is a key point, because, I mean, you have to theoretically optimize resources. I mean, so at some point, I mean, you said, I mean, to do the cytogenetic lymphoma in the blood, I mean, it's a bit, what can I say, a bit odd as a question. I mean, anything can be done, but if you want to optimize resources, that's not probably ideal. It's also surprising in CLL. I mean, I wouldn't do normal cytogenetics. We might do it, but that's a different story. I mean, you might do it for research purposes with stimulators. I mean, but that is a different story. I would certainly concentrate on fish, as you said. I mean, this is very correct. The other surprising thing is that out of 3,000 samples, only 4% were CLL. So the question would be, you're in Sao Paulo, is that right? I mean, does that mean that the other people from Sao Paulo here, does that mean that fish, either it's not done on the CLL patients, or it's done in a minority, or it's done locally? Because if it's only 4% of the samples, based on what we said yesterday, and fish is a key point, then the question is it not done, or is it done locally, or what is happening?
I work in a public hospital, and fish is very expensive test, so we do not do fish.
Exactly.
And we also don't have money to send to a private lab to do the test.
So this is a reality. Just to tie together what we were discussing yesterday and what is the real life, because it's very important. And I mean, 17p.
Yes,
I mean,
that's why I show the data.
Could really change. I mean, if the drugs, when the drugs are available, blah blah blah. But I mean, if that's the case, at least 17p should be tested. I mean, maybe you could skip the other if you want to be very practical, but that should be probably done if the drugs are not available, then it is an exercise. But sooner or later, the two things will match, and I imagine that resources have to be found at least. But I wouldn't do cytogenetics. I would then focus literally maybe only on one probe.
Usually what happened, at least in Brazil, some pharmaceutical companies usually they support the exam when they are selling a product. Sometimes they support the cytogenetics or fish or any kind of exam. So it happens frequently, but you see only 4%.
I just want to underline what Robin said and what we already discussed yesterday. So maybe you have really to keep in mind and suggest to your colleagues to ask only for deletion 17p. So when you don't need to do the whole panel, because that will save
Yes, the difference
75% of the money.
Yeah, I see the price. The price is in dollars. Is $500 the panel.
The panel,
The
yes.
panel, and one for 70 is 150.
Yeah,
It's
like
not
in
200. It's
like in
150.
Europe.
So
Yes.
it's
So
much
it's
cheaper.
still you can do
Yeah.
many more. Okay. So
Can I ask a question? So outside clinical trials, who would you ask cytogenetics with non-Hodgkin lymphoma? In which patient? In no patient? No patient.
None.
yeah. So also in the case of mantle.
Well, actually, no, that's not true. So I think we all know that MIC is associated with a very bad outcome using R-CHOP. So I would say that we now have moved to doing MIC fish for all of our untreated large cells. I don't think it's necessary to do 14, 18, but I would say MIC.
Yeah, so in fact, the point I wanted to make is not cytogenetic, but fish. So also in the case of mantle cell, sometimes you have a doubtful. Cytogenetics, not really. When you have to do something, it's better fish for MIC if you want to be. Oh.